other than our Joint Secretary, Thirumurugan Sirin from JIPMER. Over to Dr. Thiru.
Thank you, sir. Okay. When we start talking about neonatal registration, I thought that there is often some confusion because we have IAP, which does a fantastic job of conducting the basic registration program. And then we have the NNF and IAP itself doing the advanced registration program. So very often there is a bit of confusion among us. So I thought that it's my duty to kind of clarify the difference and the importance of where each of them has a role, and I'm trying to identify and clarify this role. So when we start with the program itself, I mean neonatal registration, let's look at a simple number. Let's say that I'm going to resuscitate about 2,000 babies. How many of them really would need any kind of resuscitation? So that's what my question, the question to answer. Most of them, about 1,700 of them, would start breathing by themselves. So they are our breadwinners because no, we don't do anything except drying and mopping them, and then they still give us money in our pocket. So we are happy about it. And there are some about 200 who would need not more than just they just can't take care of themselves. So we need to dry them, stimulate them, and then they will start breathing. But out of those 200, about 100, that's about 5% of them would need positive pressure ventilation. That's looking at it. I mean, that's about 5%. Okay. And less than 40 of them would need alternate airways. And please remember, these include all the preterm babies, all the high-risk babies, or your IUGR babies. So in day-to-day life, when particularly in peripheries, if you look at it, the number of babies needing alternate airways like intubation or a laryngeal mask airway is very, very small. And those who need cardiac compression is essentially 2. So 2 out of 1,000 or 2 out of 2,000 or 1 out of 1,000. And if you think of giving vascular access and needing vascular access and giving adrenaline or normal saline, then the numbers is even less, just 1 out of 2,000. So in average unit, I mean, even if you're delivering 1 baby per day, so to see a baby needing cardiac compressions, it will essentially need us about anything between 7 to 8 years. So once in 7 to 8 years. And if you think about this, so a lot of skills which we used to learn in neonatal registration, particularly, I mean, we got a lot of it from the American Academy of Pediatrics, their neonatal registration. So we used to concentrate, we get very excited with the advanced, with intubation and cardiac compression. But as you could look at those numbers, they're really not necessary in most scenarios. So the IAP, along with the government of India, came up with this program, and this program has been run very effectively and free of cost by the Indian Academy of Pediatrics to train all people, just not doctors, anybody who is involved in neonatal care. So essentially, we have got basics. In other words, though it is basic, ideally, I think the better word is actually essential neonatal resuscitation. That's the word which is used by American Academy of Pediatrics, and I think we probably are better off using it. And then we have got the advanced NRP. So the basic, this is decided only by the availability of resources and what kind of babies which we are going to handle. So if you look at it, most of these deliveries in our country happen in a PHC. We will be very lucky to have a delivery room like this, a warmer and enough space to resuscitate. More often than not, we get thrown out as pediatricians, and then babies are just handed over to us after the baby is born. I mean, not even in the same room. Of course, in places which have got all the kind of high-end facilities, you've got the monitors, you've got your infusion pumps and whatnot. I mean, you got your CPAPs, and in the delivery room, yes, definitely advanced NRP has got a relevance. So where is basic NRP relevant? First, when we think that the newborn does not have any significant risk factor, that could be either perinatal for the mother from the maternal point of view or from the newborn point of view. And second and most important is that if the baby is going to be born at a site and we are going to continue to care for the baby, if you think this baby is going to need the transfer after delivery being born, you are better off referring the baby to a place where they could handle those babies. Okay, so basically we are talking about smaller hospitals, clinics, and PHCs and those kind of stuff. And what equipment we will need? This will be gone in detail with the basic NRP program, discussion. But pretty much you need a resuscitation area, preferably with a warmer. You need a suction. Again, lucky to have an electrical operated one. Definitely we need oxygen and an amber bag. Last but not the least, you should have an ambulance. So if you get into trouble, you should be willing to transfer to the nearest healthcare facility with no delay. So we should, and that's what it is. And how many people do we need? Basically, we need one trained person. That could be a physician, it could be a nurse, registered nurse, it could be a DAI, it could be a nursing assistant, anybody who is going to handle the baby soon after delivery. And of course, we need a helper. One person cannot do everything, so we need a helper. And again, that helper need not be somebody who is highly educated. It could be an ordinary person. Advanced NRP is all about high-risk newborn care. Okay, so essentially, it's more restricted to larger hospitals and teaching hospitals. Equipment-wise, apart from basic NRP, we need a pulse oximeter. And now with the changes happening, we need a ECG monitor also. Definitely a blender. We should have capabilities for intubation or use of laryngeal mask airway, preferably a CPAP, and facilities to do a vascular access. And look at the difference. I mean, we need 4 to 5 trained persons, a team leader, an assistant provider who can take care of the airway, another one who can take care of the circulation, a helper, and last but not the least, a scribe who actually documents everything as it goes. I mean, in a stressful scenario like resuscitation, neonatal time does fly away, and we often forget the details too, and that often gets us into the lot of medical legal muddle. So, just to run through the process, again, it will be talked in detail. So basic NRP is all about temperature, airway, breathing, and because please remember, it's only about you. I'm the only person available, so you cannot jump between airway and circulation trying to give cardiac compression. So either you wait for help, or if not, try to take the baby and run to the nearest facility where we can continue with the resuscitation and beyond. That is, advanced NRP is about everything from temperature, airway, breathing, circulation, and of course, vascular access and drugs. Now, let me just complete by saying that how often we should train. Most of us feel that we have trained once, we are happy, but please remember that if we don't use our skills, and we often tend to forget. And so, according to the American Academy of Pediatrics, the recertification should be done every 2 years. That means all of us should train every 2 years. So, and luckily for us, the Indian Academy of Pediatrics is offering free training of basic NRP in every place, and I request every individual branches to if you are from Pondicherry, of course, I am the state academic coordinator, and if you are Chennai, it is Dr. Prakash, who is the state academic coordinator. I mean, from Tamil Nadu, it is Dr. Prakash, who is the state academic coordinator. We will be more than happy to organize basic NRP programs in all over Tamil Nadu and Pondicherry with the aim of training